Hi, good afternoon, everyone. My name is Atul Laka, and welcome to this afternoon's deep dive session. Just a few housekeeping rules. So all the talks are recorded and can be found on the Blood Assay website. This is an interactive session, so please post questions or comments in the chat box, which will be addressed after the guest speaker has spoken. If you're not on the regular mailing list, please email Melanie Davids at the displayed email address. These talks are CPD accredited, and a minimum of 1 hour's attendance is required to qualify for the CPD point. Kindly complete the anonymous feedback survey at the end of the meeting. Just a reminder of some upcoming events. The South African Bone Marrow Registry proudly hosts the 14th International Donor Registry Conference and World Marrow Donor Association meeting, which takes place in Cape Town from the 25th to the 29th of June, with a discounted rate if you're affiliated with Satiba, Sashes, or Blood SA. In addition, the 16th Heme-Onc Symposium takes place from the 13th to the 15th of September at Century City Conference Center in Cape Town. And similar to previous Heme-Onc meetings, it promises to be very informative and useful. Before I introduce our guest speaker for this afternoon, I'd like to acknowledge Prof. Verburg's dedicated Blood SA team for the great work that they've been doing over the years. And this afternoon, it gives me great pleasure to introduce our guest speaker, Professor Toba Tsabetse, who is an associate professor in the School of Clinical Medicine at WITS. He is the academic head of cardiology at WITS and the clinical head of cardiology at Charlotte Maxeke Johannesburg Academic Hospital. He serves as an executive committee member of the South African Heart Association and South African Hypertension Society, as well as the president of the Heart Failure Society of South Africa. He was admitted as a fellow of the European Society of Cardiology in 2022, and is passionate about undergraduate as well as postgraduate teaching. I just wanted to confirm if Professor Tsabetse is on the meeting and if we can proceed with the talk.
Yes, I'm on the meeting. Are my slides visible?
Yes, yes.
Am I audible?
Yes, you are.
All right. First, I'd like to say thank you to the organizing committee for inviting me to come and share some insights on cardiac amyloid. I believe I am speaking to hematologists this afternoon. I am a cardiologist, so I feel like a fish out of the water, but nevertheless, we shall find common ground and draw insights from this lecture today. To just continue, these are my disclosures. And for the next 30 minutes or 40 minutes or so, I'm going to be discussing the elements that you see, really looking at a deep dive into AL light chain cardiac amyloid, but we'll be giving an overview of amyloidosis and how to approach the condition. We'll be reviewing the pathogenesis of cardiac amyloid, the pathologies associated with amyloidosis, an approach to diagnosis, and then a few comments on treatment responses, some gaps or unmet needs, and then a few take-home messages for the audience. So as an abstract or a headline summary, I've put these salient points just to quickly sum up the core of what we're going to be discussing. And briefly, amyloid or amyloidosis, really it's a systemic disease. It's rare, it is progressive, very debilitating, and often when diagnosed, a fatal disease for most of our patients. It's much more common in men with the median age of diagnosis at 65 years. And really, where we as clinicians can make an impact is on timeous and judicious diagnosis, timely, so that we could treat our patients. One can appreciate that the range of survival spans from 4 months to about approximately 2 years, depending really on whether the disease at diagnosis was less severe to a more very advanced disease, which has a very short lifespan. And although there are many different forms of amyloid fibrils that have been described, we're really going to be focusing on the most common, which really boils down to the systemic immunoglobulin light chain derived AL amyloidosis, which accounts for 53% according to contemporary literature, as well as the systemic transthyretin derived ATTR amyloid, which accounts for 42%. And these two are the most prevalent, with the shift in aging towards ATTR. But as hematologists, I know AL amyloid is really the crux of your bread and butter that you want to hear more of. And to begin, I want to give the global view of this condition and really spend some time on this slide just to bring in certain key points in terms of the nomenclature, the precursor proteins, the age range, the gender or sex at presentation, and some of the clinical clues and the laboratory abnormalities that we see that we need to tackle. Now, as I've highlighted, AL amyloid, the precursor protein being the light chains, typically affects both males and females equally, with a middle age group peak of approximately 50 years. It is multi-organ, and later on I will show you some illustration of various organs that may be involved in some patient pictures as well. You can see typically periorbital bruising, the macroglossia, and these are almost pathognomonic, especially accompanied by cardiac imaging that is highly suggestive. And importantly, this is the form or variant where many of our medical registrars always remember to do the electrophoresis. And here we have elevated serum-free lambda or kappa with abnormal ratios, and we may have a monoclonal spike in serum and or urine. And of course, with that, we have then other suppressed immunoglobulins, and also tends to be associated with proteinuria. And that's the prototype of AL amyloid, which I think many times most of our students can appreciate, and it's what they assume the dominant form is. Now, there are then these two other forms, the most common being the ATTR, which is separated into two variants. We have the wild type, and we call it wild type because this is the normal variant that just occurs. And then we have the mutant variant. But first, looking at the ATTR wild type, this occurs in much elderly individuals, 65 and above. It has a 15:1 male dominance ratio. And note here that generally there's no other organ involvement. Some patients may have a history of other manifestations such as carpal tunnel syndrome, and there are no specific abnormalities here with regards to free light chain values or proteinuria. And again, this may be often a confusing element, because when one does these tests and finds nothing, then they assume, oh, it's not amyloid, and forgetting that there are these other variants that may manifest slightly differently. And now between these two, both AL and the ATTR wild type, you're really looking at about 80, almost 90% of all forms of amyloid that one may see. Then it's important for me, for completeness, to talk about the ATTR, the mutant transthyretin. This is the form that currently there's a lot of therapy that's available. And here, again, the age range is about 40 plus years. And we can see it tends to have an African predominance, African American, African Caribbean, for this specific V122 1 TTR variant. Again, no specific abnormalities on routine testing, and often genetic testing reveals the mutation, which is then definitively diagnostic. Then the other form, which physicians tend to battle with again, is what we call the AA, or the secondary amyloid. And this occurs really as an acute phase protein. And now note this much younger age predominance of between 20s and 30s.
Wow. What is going? I mean, told you, hungry. He needs to eat.
Hi, good afternoon. Could you please mute yourself? Apologies, you may continue.
All right, thank you. Apologies for that. I wasn't sure whether we have been hacked. Let's continue. So the last form, as I mentioned, is the AA secondary amyloid, which is an acute phase protein occurring in much younger individuals. Here we're looking at 20s to 30s and upward with severe inflammatory disease. Again, equal male-female predominance. And usually these patients have an underlying chronic inflammatory condition associated with the typical infective or inflammatory biomarkers, high ESRs and CRP, and there may also be proteinuria. And on clinical examination, one may find manifestations of hepatosplenomegaly. Again, usually no cardiac involvement with this manifestation, but in rare cases, it may also be severe. So this is nice to have this table because it almost at a snapshot gives you a quick feel or review of some of the salient features and really the complexity of the condition that one needs to be aware of. Now, honing in on AL amyloidosis, what we note here is we have essentially bone marrow where immunoglobulins are formed. These then would develop the light chains, would then have light chain misfolding, which then leads to amyloid fibrils. And these amyloid fibrils then get deposited into the interstitium between these cells, and it's looking specifically at the heart, causing then a restrictive cardiomyopathy phenotype. And if we take this further in this cartoon, what you can appreciate here is the normal heart, and we have here the cardiac myocytes, and the two dominant forms of amyloid fibrils, the light chain proteins that are misfolded, which then get deposited into these tissues. And similarly, we have here the transthyretin proteins, which are liver-derived, and these also become misfolded. So these light chains from the bone marrow, transthyretin from the liver, and then these become deposited in the myocardium, giving rise to the typical cardiac manifestations that we see. Now, if you look at some of the postulated mechanisms that cause the progression of the disease, what one can appreciate is we've got two destructive mechanisms, both a structural damage as well as a proteotoxicity from the proteins themselves. And you can see these leads to sequelae at a cellular level, stress kinase activation, lysosomal dysfunction, an acceleration of reactive radical oxygen species, leading to cell dysfunction, defective mitochondria, and eventually cell death, which may not be controlled as an apoptotic. Then in the structural damage, simply by having these proteins in the interstitium, what we can see is an increased cardiac and vascular stiffness, leading to impaired contraction and relaxation and disturbed electrical conductance. And we'll see some of these manifestations in terms of some of the tests that one does at the bedside, and how we then manifest these and how these can be treated. Now, looking at this autopsy specimen, again, this is an autopsy of a heart. You can see on my left, this thickened septum between the left ventricle, this is the right ventricle, and these are all the deposits of these amyloid myofibrils. And even here in the atrial lining, one can see this glossy substance that is shining through. This is not atherosclerosis, but rather these amyloid fibrils. And what they've actually done is even caused thickening of the interatrial septa. So the usual size of this is usually almost paper thin, but you can see here very fleshy and thick, leading to the typical restrictive cardiomyopathy phenotype that we see, that we will discuss shortly. Looking again at H&E staining, And one can see again the perivascular deposits in the intramyocardial cellular, again, just leading to this thickening and defective manifestations that one can see for these patients. So looking now and focusing on the cardiac manifestations, as I've highlighted, it's the most commonly involved organ in AL amyloid. More than 75% of patients have symptoms of cardiac infiltration at diagnosis. And cardiac amyloid infiltration is the leading cause of death, according for the majority of fatalities. But despite this dominance of cardiac manifestation and dominance in terms of cause of death, I wanted to also highlight these other causes or manifestations that one may need to look out for. The periorbital purpura, and I'll show you a picture shortly, the macroglossia, and the percentages below is just the incidences that these have been reported in currently available literature. Cardiomyopathy, as you can see, very, very common. More than 75% of patients may manifest with this. Hepatomegaly, 50%. Peripheral neuropathy, 10 to 20% of patients. Nephropathy, 60% with glomerular involvement, and that's also the mechanism for the proteinuria that we see. And then approximately 7% may also have GIT manifestations with motility problems, may even in severe cases complicate with perforation. Autonomic neuropathy, 20% of patients, and these may present with orthostatic hypotension, postprandial diarrhea, and even erectile dysfunction. But by and large, one can see the heart, the liver, and then the kidney, typically the organs that are generally affected, and the heart really lending itself as a low-hanging fruit to scoop the diagnosis if one is alert and judicious in their clinical approach. In this clinical image, I'm presenting the two manifestations. We've got the periorbital spontaneous bruise that patients may complicate and present with, as well as the macroglossia. And when one looks at this, one may even think, could this be acromegaly? But this is very unique in that it's only the tongue that is significantly enlarged, whereas with acromegaly, there's typically all other soft tissues that are under the effect of insulin growth factor that are abnormally enlarged, with both the nose, frontal bossing, and the prominent chins, etc. But here it's just only the tongue. Again, thought of to be this extracellular deposits of the amyloid myofibrils. Now, the substance of what we want to clinicians to be quite acquainted with is how to approach these patients. So in a clinical setting where there's a suspicion or a patient would presenting with cardiac failure or restrictive cardiomyopathy of unexplained etiology, this is really the workup or the pathways that one needs to follow. There is a supplementary slide I'll also show in the next slide shortly. Most readily accessible imaging tools, the echocardiogram, which one is able to review. One may also have an MRI suggestive of cardiac amyloid with typical infiltration pattern throughout the entire of the myocardium, as well as the thickening of the interatrial septa and atrial septa, as well as the atrial walls. And from this clinical, one can then approach laboratory investigations. Your typical investigations would include those confirming heart failure, the NT-proBNP, the troponin T, then the serum protein electrophoresis, serum immunofixation, and the free light chain assays. And as you know, the latter more prominent and commonly abnormal in AL amyloidosis. And if the plasma cell dyscrasia is present, that's when you would then proceed with a bone marrow biopsy, with or without cardiac or even other organ biopsies, non-cardiac biopsies. We talked about the kidney, for example, we talked about the liver. And then one would subject these to immunohistochemical chemistry imaging, and if strongly positive for light chains and negative for transthyretin and amyloid deposits, you've basically made your diagnosis. And sometimes it may show ambiguous results. And then in that case, one may consider mass spectrometry, which confirms light chains in the amyloid deposits. And then one confirms the diagnosis. So here, really, the presence or absence of the plasma cell dyscrasia, a critical juncture where directing your path as to how to proceed in terms of the workup of the patient. If one considers if that there's an absence of plasma cell dyscrasia, one needs to consider the myocardial uptake, and this is where we then utilize our imaging, advanced imaging from nuclear medicine. This is a technetium diphosphonate scan or the pyrophosphate scan, which one may do. And if this, again, is strongly positive, the question, is there transthyretin protein mutant present? If yes, then one can confirm the hereditary form caused by the genetic mutation. And if it's not present, then one may consider the non-hereditary form caused by the wild type. If, however, after this workup, there's no plasma cell dyscrasia, the nuclear imaging studies are also negative, then a cardiac amyloid becomes unlikely, and then one may proceed with endomyocardial biopsies if clinical suspicion is still indicated to try and further investigate these patients. But by far and large, most patients, when one has followed this pathway, we are able to already make a definitive diagnosis. Another way to look at it in terms of diagnosing AL amyloid, this is just another pathway where you're suspecting amyloid. You can then do the various immunofixation processes. And if amyloid is unlikely, you can do then if that means these are negative, no plasma cell dyscrasia, you do the nuclear scan, and if non-cardiac affected organ biopsies, or you may consider genetic testing. If these are positive, one already has a high suspicion, you may consider tissue biopsy with Congo red staining to detect the amyloid deposits. And if positive for the amyloid fibril typing, which then confirms the AL type, and then one may continue doing the full systemic assessment for the patients. If negative in terms of tissue biopsy, you may consider repeating the biopsy or change the biopsy site. So if these are positive, then systemic amyloid affecting one or more organs is diagnosed, and then comes now with staging, and then the necessary treatment approaches that one needs to consider when managing these patients. Because the ECG is a readily available test at the bedside from the emergency department in your medical wards, it also hides or has a lot of clues that may make one very suspicious. Now remember, because of the myofibril infiltration, the myocardium is often very thickened. And in most cardiomyopathy conditions, when you find thickened myocardium, be it hypertensive heart disease, be it a patient with hypertrophic obstructive cardiomyopathy, and other forms of diseases, we would expect very prominent R waves in terms of R wave progression. But what's very peculiar in this condition is that on imaging, you find thickened fleshy myocardium, but very low limb lead voltage. And here we can see an indeterminate axis. So there's poor precordial R wave progression, which then is suggestive that this could be an amyloid manifestation. Now, here in this picture, you can see it's a typical echocardiogram. Unfortunately, I don't have the codecs to play the videos, but you can appreciate the thickened myocardium. In this view here, this is the apical four-chamber view. You've got the left ventricle at the top, and this is the left atria. This is the right atrium, and this is the right ventricle, the mitral valve, the tricuspid valve, and this is the interatrial septa, and this is the interventricular septa. You can see there's already features of pericardial effusion that we can see here, this space outside of the right ventricle, and one can appreciate the very thickened and ground glass appearance that we see in this patient. And what you see here is the tissue Doppler signal, again indicating low tissue signals in terms of the poor contractility that we see in these patients. And one of the typical hallmarks that we also use is the speckled tracking, which looks at myocardial deformation. I know this may be slightly advanced for the audience I'm speaking to, but I'm just trying to illustrate that there are these advanced imaging techniques that we can do again at the bedside to confirm in the impact of the disease process on both the atria as well as the ventricles. And here we're looking at typical impaired atrial function in cardiac amyloid despite being in sinus rhythm. And this is measured by strain imaging. So what this shows is that the atria not only are also affected, but they're not contracting optimally. And this is the different speckle tracking mechanisms and the measurements and reporting of these. Here again, this is a patient that we managed recently in our hospital where this diagnosis was made. And in this video, we could see again the typical thickening of the myocardium in keeping with amyloid myofibril infiltration. And this is the apical four-chamber view, zoomed out. That's the left ventricle, the left atria. You can appreciate just how thickened this interatrial septa, and this is the interventricular septa, also the right ventricle and the right atria, and there's already this pericardial effusion. So really a typical image similar to textbook manifestations that one reads of this condition. And then I'll just get through these images because they don't play. Yes, so now one of the other hallmarks that if you do suspect cardiac amyloid, that I would recommend or advise that you request your cardiologist or cardiac sonographer to perform is what we call speckle tracking straining imaging of the left ventricle. So with every systolic function, the left ventricle contracts and relaxes. And what one can do with speckle tracking is measure myocardial deformation. And so in amyloid, generally, for some reason, which still hasn't been elucidated adequately, the myofibrils largely are deposited in the septal and the lateral walls at the base and the mid-ventricular walls. And generally, the apex tends to be spared from complicating with this condition. And hence, as you can see here in this 17-segment model, is that the apex, which is the center of the bullseye appearance, has greatest myocardial deformation, which means from contraction and relaxation, there's greatest movement of the heart muscle, hence a greater negative value. And then one can see as we move towards the bases of the heart, this negative value decreases. And so it just illustrates again a typical phenotype that we see on imaging, indicative of amyloid in cardiac imaging. And here you can see even in the patient that we were treating, we actually had a typical manifestation indicating that we're dealing with amyloid. There are other modalities of imaging, cardiac MRI, and I'm just sharing this for completeness sake, and with various imaging sequencing protocols at various time ones. These are T1 weighted imaging, and one can see the differences in terms of the uptake in the myocardium and at these different time frames. Again, these are pathognomonic, and if you have a good cardiac MRI operator, again, they're able to almost conclusively tell you you're dealing with cardiac amyloid. Now, this talk wouldn't be complete without the nuclear imaging. Remember, earlier on in our pathway, we talked about first step, determining the presence or absence of the plasma dyscrasia. If that's there, you then immediately proceed to bone marrow and confirming that you're dealing with AL amyloid. And if that wasn't there, the next step was to consider the nuclear imaging. And here we're looking at the DPD scan, the pyrophosphate scanning. And in ATTR, as you can see, there's a myocardial uptake with technetium-99 pyrophosphate scanning. However, if the patients have AL amyloid, you will not get the cardiac uptake that you expect. And this is similarly shown here in the SPECT imaging, where we have ATTR myocardial uptake of technetium-99 pyrophosphate and no AL myocardial uptake in this imaging. And it's important that we don't get confused, because often when either the electrophoresis comes back as negative, some colleagues may consider the patient not to have pathology, or either when the nuclear scan comes back as negative, some colleagues may consider, oh, there's no AL amyloid. But if you follow the processes and the steps accordingly, one is able to clinch a definitive diagnosis and initiate treatment accordingly. Now, I've covered the clinical manifestations. I've covered the bedside investigations that one may do, and just want to really sum up now on some of the key pertinent points on approach to treatment. And these are some of the anti-plasma cell dyscrasia treatments that have been presented and anchored as key to treating AL amyloid. High-dose chemotherapy with stem cell rescue. All patients need supportive care to maintain organ function, immunomodulatory modulators for refractory disease, and the backbone of therapies, daratumumab, the anti-CD38 monoclonal antibody, together with dexamethasone, bortezomib, proteasome inhibitor, as well as cyclophosphamide and melphalan. And I'll show you how these fare. But these are the principles of therapy that currently are used in 2024. So in a newly diagnosed AL amyloid patient, majority of patients, it's generally combination therapy where we have cyclophosphamide, bortezomib, as well as dexamethasone, together with daratumumab. 90% of patients usually will start here. And then in a few minority of patients, they would usually have the autologous stem cell transplantation without induction. And then really what we're looking for here is now whether patients have had a complete response or not. And most, if they have a complete response, then they get monitored. With relapse, then one may consider again if they are eligible for autologous stem cell transplantation or not. And if they are, we proceed. If the clinical response, however, is suboptimal, we immediately consider autologous stem cell transplant at the same time. And at that stage, we may consider what's the burden of bone marrow plasmacytosis. And if it's more than 10%, it's a good time to proceed to ASCT. If it's less than 10%, and we had a very good partial response, one may monitor for improvement of organ function and ASCT or other chemotherapy if no involvement of organ function. However, there are some patients who may not have a good clinical response, who may not be eligible for ASCT, and more alternative therapies may be considered, such as anti-plasma cell dyscrasia therapies, which may be considered. And similarly, with those who relapse who are not eligible. So there are alternatives to these therapies, but I won't go into that. Besides, you are the experts in terms of which agents and selection that one would then tailor in this particular subset of patients. Some of the current therapies, these are the anti-plasma cell dyscrasia treatments. We're looking at cyclophosphamide and melphalan. These are alkylating agents that damage DNA, resulting in apoptosis. Bortezomib, as I mentioned earlier, a proteasome inhibitor, forming a reversible adduct with the 5-beta subunit, resulting in apoptosis as well. Dexamethasone, which induces apoptosis via the nuclear glucocorticoid receptor. Daratumumab, with this, as I mentioned, an anti-CD38 monoclonal antibody, and the only antibody approved for treating AL amyloidosis currently. And then we may, after high-dose chemotherapy with the autologous stem cell rescue, and with for all patients, comprehensive supporting care to maintain other organ function and to support and prevent organ failure. Okay, so these are all the current therapies, and some of the new or novel emerging therapies are therapies that look at how do we rid of the myofibril deposits that have occurred. Because so far, if you holistically review the therapies that are currently established, they look at preventing worsening or further deterioration of disease. But some of the emerging therapies, we're looking at therapies that can try to break down and prevent the accumulation of these misfolded proteins. And these are some of the molecules that are currently in clinical development and clinical trials and being tested to see if they can help in terms of preventing and removing the amyloid myofibrils in the various organs and tissues where they may be deposited in. Now, briefly, just some of the criteria. Earlier on, I mentioned clinical response. So clinical response is measured or categorized differently according to the type of organ that's been involved. There's hematological, there's cardiac, there's renal, there's hepatic. And really, that's important because it determines then the next step of escalation of therapy. I'm just going to focus on the cardiac involvement, where we're looking at a decrease in one of the cardiac biomarkers for heart failure, the NT-proBNP, by more than 30%, as well as a more than 300 picogram decrease if the NT-proBNP at baseline was more than 650, or a 2-point decrease in New York Heart Association functional class if the baseline was functional class 3 or 4. Then that would be considered a good clinical response. And you'll note for the others, in terms of the kidney, you're looking at proteinuria and a drop in proteinuria and GFR improvement, as well as hepatic, you're looking at a decrease both in radiographic size of the liver, as well as abnormal alkaline phosphatase levels. And the hematologic is really looking at the absence of amyloidogenic light chains, defined by negative immunofluorescence of both serum or urine, as well as either an FLC ratio with the reference range for uninvolved FLC concentration greater than involved FLC concentration, with or without an abnormal FLC ratio. And so you can see these are all various parameters. And in some units who manage these conditions, they may have certain criteria that they use or certain pathways, but I'm presenting today some of the generally accepted guides in terms of escalation of therapy. Now, if one considers, again, the hematologic response to first-line therapies, one can appreciate really that the first two, and especially the daratumumab as well as the Cyborg combination, achieving approximately 78% clinical response. And if you look at the ASCT, achieving about 73%. And hence, that's why these two are generally the first two that are go-to strategies in managing these patients. And then some of the unmet needs or gaps where further research is still needed in terms of clarifying and answering certain questions. First, with respect to treatment, primary therapy varies, especially with limited drug access in various areas. And these therapies are needed for relapse or refractory disease and to remove the amyloid deposit. So this is a quest that is still ongoing, because we've realized we can now stop progression of disease, but how do we cause regression and removal of these? There's also no standardization of the supportive care that patients may be given. This is all respected to treatment. And in terms of clinical response, generally, it's set at about 50%. And one may argue, why not increase or decrease that threshold to 25% or 75%? And as well as the issue of poor survival in advanced disease. And I think that really looks at the damage caused by the structural deposits of the amyloid myofibrils. And so with these future therapies, perhaps we may see improved outcomes or better outcomes for patients with advanced disease. And then in terms of the endpoints, the need for consensus on timing of the hematological response. When should one, once you've started therapy, when should one then monitor to assess if there's been adequate response or poor response? The longitudinal response to therapy over time, and primary organ responses as well. As I mentioned, we've only looked predominantly at the heart, the liver, and the kidneys. And then there are these varying unit approaches, globally in these centers of excellence in terms of what they use as a cutoff. And then in terms of endpoints on quality of life, reducing amyloid burden, as well as other comorbidities, again, just to get a consensus on those, so that if perhaps starting therapy may be futile in certain patients, we need to be talking the same language so that patients don't hop around to various centers and search for therapy. Whereas if there's varying definitions of when what those endpoints may be, we expose ourselves to that risk, where in some cases where therapy may be considered futile and patients should attend more of a palliative care approach. But in some centers, they may actually start treating those patients. And we need to have some form of uniformity on that. So these are some of the unmet needs and gaps that need to be addressed and consensus amongst the global community. So in conclusion, there's definitely an acute need to increase awareness of AL amyloid. I encourage you tomorrow when you go into your ward rounds, into your clinical platforms, test and see how many of your colleagues are aware of the condition and the different forms and types. And I hope that this lecture has reignited and made you aware of some of the pertinent differences. Importantly, early diagnosis and correct treatment selection are critical because that's what determines ultimately the outcome. So patients often get lost in the clinical arena where there's no diagnosis, they treated for symptoms, but no one's actually pursuing to make a definitive diagnosis. And it's only later with advanced disease that suddenly the thought of investigating this patient comes to mind. And I would say when there's a high index of suspicion, definitely pursue the full workup. And we now have a good imaging support to give us important clues to pursue the diagnosis. Importantly, survival does depend on cardiac staging of the disease at diagnosis. And the heart, for some reason, is one of the prototype and principal organs that is affected. And as I highlighted in my earlier slides, accounting for more than 60% of the mortality that we see. So the patients actually eventually die of cardiac failure. And so combined targeted amyloid removal with current therapies may improve outcomes in the future. And the challenge, I guess, for us is how do we increase access for our patients and timely diagnosis to achieve better outcomes. On that note, I'd like to say thank you for the invitation, and I welcome any comments, any questions from the audience, and I'm handing over back to you, Chair. Thank you very much.
Thank you for the excellent and comprehensive overview, Prof. There are a few questions on the chat group, and perhaps I could start. So, many years ago, they highlighted the use of doxycycline as a form of antifibrillar therapy, particularly useful in the setting of cardiac amyloidosis. What's the latest on that? And in a setting that's resource limited, like the state facilities, is there still a role for doxycycline in patients with cardiac involvement?
Yeah, so as you can note, many of the agents I've talked about and the excellent outcomes, I mean, to get a 78%, 73% is an excellent outcome from these conditions when diagnosed early. But in state sector, we are very much limited both by cost as well as the access. And many of the patients may come from very remote and far areas. And so in the state sector, as I mentioned, if I were to go back in my slides, just to go to that diagram, where you can see these various other options and the response, one can easily appreciate why we do use these less effective therapies. It's really us trying our best. And because of the limited access and cost, we often have to do something and just leave the patient. You can see that some patients do have some responses, but as you move down the various options, becomes less and less. So yes, it may be tried, but there are these superior therapies, and these are evidence-based therapies. And if cost is not a limitation, these would be strongly recommended. And I guess since we are in South Africa, I would hope, I know some of you may have different takes on this matter, I would hope that the NHI addresses these issues, that we can get access, universal access for everyone at a better cost. But yes, my answer simplicity is when you're stuck between a rock and a hard place, you can't leave a patient You have to discuss the pros and cons, indicate that the support, the success may not be robust. There are better therapies, but we give the best that we can. But again, I'd like to hear other experts on the call. What are their take? Some may take it's unacceptable, but often that's what I find when you go, especially when you go to remote areas where even just chemotherapy is not readily accessible. There are very few centers that will have such therapies readily accessible.
Thank you for that. And any possible mechanism of how the doxycycline actually benefits, as a form of antifibral therapy?
Not at the top of my head in terms of contemporary research. As you highlighted, it's an old therapy, and a lot of the research now is unraveling the new therapies. We haven't utilized it, fortunately. So I haven't really reviewed how it would work in those patients where it may be used. Apologies for that. Again, if there are experts in that field, I would lean on them and ask them to please come forward. Thank you.
And then just an important comment from Andrew McDonald, considering that both AMGAS and transthyretin amyloid are more common in elderly and actually may coexist, in his opinion, that if there's an abnormal serum-free light chain, it does not equal AL amyloid, and these patients still require bone marrow. But a technetium scan could be performed as a much less invasive test than an endomyocardial biopsy. On that note, perhaps we could ask other centers and particularly pathologists, typing the type of amyloid can be quite tricky. They recommend using immunohistochemical stains for kappa and lambda, but these can be difficult. And if you don't have much experience, these results could be misinterpreted. And as mentioned later in the chat, that mass spectrometry is not readily available in South Africa. Just some feedback, perhaps from pathologists or other centers. How are you able to distinguish your various types of amyloid?
Looks like there's no response.
Yeah. While we wait for a possible answer, do all patients with suspected cardiac amyloid require an MRI? And what additional information will it provide that would be of a prognostic or therapeutic benefit?
Yeah, so MRI is not a prerequisite for these patients. It's a nice tool to have because it often you're able to do more objective assessments than the echo. But again, with the echo imaging that we now have, as I've shown with the spectral tracking, one is able to really coin the diagnosis quite confidently. What MRI does best, though, is the infiltration patterns, as well as the gadolinium enhancements and the typical phenotypes that amyloid would have. But invariably, most centers, before they actually start any form of chemotherapy, they want some form of tissue diagnosis. So even if you've got the clinical suspicion, you have the imaging that supports your suspicion, often, ultimately, they want the tissue diagnosis, and only then they will start. And again, before one starts, one needs to then assess the burden of disease so that when you start the treatment, one is able then to document the response to therapy, like some of those parameters that I've shown. Note that from what I showed you, there were very little, if any, imaging parameters. A lot of them were biomarkers. that were being utilized, looking at the plasma cell dyscrasia burden, looking at the cardiac biomarkers. So short answer, it's not that it's a must, it's a nice to have. So it's not that every patient must be referred for MRI. I think the main issue, as you saw, is some form of imaging to confirm your clinical suspicion. And then you do your electrophoresis. And if you have plasma cell dyscrasia, then you follow that pathway. And if not, and you're still suspicious, you go the nuclear medicine route for the ATTR. Yeah. Hello, Chair, you still there?
Apologies, Boba.
Oh,
I
okay.
wanted to, I didn't realize that I was muted. I want to find out what's the role of monitoring your cardiac biomarkers like proBNP and troponins. How often do you need to monitor them? And tell us a bit about their prognostic significance. I believe I see that they are important in the staging as well.
Yes, yes. So these tools are, these molecules obviously, or biomarkers are readily accessible. Almost every hospital will have these. And it's an objective measure to monitor the disease process. Remember, we talked about the heart being the driver of fatalities in about 60% of patients. So when you start therapy, if you're able to see a decline in these cardiac biomarkers, both proBNP, which is a marker of myocardial stretch, indicating that the heart is overloaded, and troponin, which is a marker of cardiac myocyte death. That's when it's released. And that would occur from the apoptotic pathways that we talked about earlier on in the pathogenesis. So when patients are being treated and these numbers are decreasing, that's very indicative of a good response, that the patient is responding well to therapy. And so also, should a patient have a reoccurrence or worsening, when these markers climb up, it tells you that the patient is deteriorating, because most of the heart failure symptoms, they're very much non-specific. And sometimes it's difficult to tell, is it really worsening disease, or is it just the patient now not feeling well? Maybe there's elements of depression coming in, etc. And so these are good objective measures that can be used as a trigger when to intensify therapy and when to reconsider a new therapeutic approach. So that's very important. And these are, as I said, many hospitals have these tests now available, and it's good to objectively monitor response to therapy.
Thanks. Another question is, any tips on mitigating risk in amyloid patients going for an autologous stem cell transplant, especially in view of the autonomic instability? And is there a role for beta blockers in terms of managing arrhythmias? Perhaps you could tell us a bit
Okay.
about.
Yeah, I'll tackle the second one. I'm not an ASCT expert, but in terms of the therapies, currently we do treat these patients fully with all the foundational therapies of heart failure with reduced ejection fraction. So you're looking at beta blockers, you're looking at the MRA, mineralocorticoid receptor antagonist, the SGLT2 inhibitors, either dapagliflozin, empagliflozin, as well as ideally the ARNI, which is a combination of sacubitril valsartan with neprilysin inhibition. And those are the four principal therapies that we use to improve outcomes in heart failure. And so these therapies also have been reported to slow down or prevent worsening of the cardiac remodeling which occurs. And that's really the nidus, which then leads to arrhythmias and subsequently sudden cardiac death risk that some of these patients may have, and becoming a nidus for VT, VF, AF, etc. So beta blockers are principal therapy. It's a class 1A recommendation, together with these other agents that I've highlighted that should be used as heart failure therapies to treat these patients.
Any caution with vasodilators, like ACE inhibitors or ARBs in managing the heart failure with these patients?
Yes, one must be cautious for the hypotension that may ensue from these patients. So slow titration. Also remember the amyloid may also cause the renal dysfunction. So you have multiple mechanisms of renal dysfunction. So in that setting, especially when you have acute and chronic worsening of the renal dysfunction, one needs to be cautious about the use of RAS blockers in these patients. And so ideally, one should do it judiciously, close monitoring for the patients to avoid any adverse effects earlier on. So yes, that has been reported, and it is a concern, but with the judicious clinical monitoring, one is able to circumvent it. And again, just like with most of the other heart failure therapies, we usually start very low dosages of therapy, and then we slowly up titrate as patient tolerance, looking at both heart rate response as well as blood pressure response, and giving patients maximum tolerated dosages.
Thanks. Just another comment from Sharoch. The addition of doxycycline to SIBOD failed to prolong progression-free survival or to improve hematological or cardiac response compared with SIBOD alone in 140 patients with stage 2 or 3 cardiac amyloid. And this is from a study published in 2022.
Yeah. No, that's good to share these data. As I mentioned earlier, often what happens is when you stuck and now you're not sure and you don't have access, this is when individuals would go for these therapies. But perhaps with this new contemporary data, the question of futility may come in. But I don't know whether one would accept and say, I can't do anything and do nothing. As there are some others data that have suggested some benefit, but clearly RCT recently published indicating perhaps not a good data source. Thank you for sharing that. Was it Sharok?
And then perhaps we could take one last question from Moses. Any role of low-dose lenalidomide maintenance in cardiac amyloidosis after consolidation, given the feared toxicity of the immunomodulatory drugs? And I think perhaps they do often say that the IMiDs aren't well tolerated in patients with amyloidosis. And I think it depends on, the extent of the amyloidosis and all the organ dysfunction that it's causing. But if you have access to it, we personally don't have access to it. We would still consider thalidomide as a possible drug for maintenance. However, the feared peripheral neuropathy may be limiting its use. I'm not sure if anyone else from other centers would like to comment on that. If not, then it leaves me to thank Professor Tabetse for great overview. So next week, we will be reviewing the topic of a plasma cell leukemia. And please remember to complete the anonymous survey at the end of the meeting. Thank you, everyone. Have a good evening.
Thank you, and thank you for having me as well.
Thank you.